So to start the section, we honor to have Professor Liu Jin-Su, Director of International Medical Service Center at Taipei Veterans General Hospital. Professor Liu is a distinguished expert, and he will be sharing his intensive knowledge on living donor liver transplantation for hepatoma. So please join me in giving a warm welcome to him.
Thank you, dear guests. Ladies and gentlemen, I'm very honored to be here to talk about the role of liver transplantation in HCC treatment. And actually, I will share the experience of our hospital in recent 2 decades. Liver transplantation is one of the many treatment modalities for HCC, and it is recognized and gain popularity more and more as the role in curing HCC recently. Since 2004 until 2024, we performed about 800 liver transplantation cases, with more than 70% were living donor liver transplantation. Actually, from 20 to 40% of the cases were patients with hepatocellular carcinoma. HCC patients were tried to be cured since 1970, but the outcome were reported at that time was usually poor. But some ideas were raised. The tumor burden and tumor biology were associated with outcome. The famous Milan criteria was a prospective study which select the patients for liver transplantation with solitary tumor less than 5 centimeter, or tumor number less than 3, and each tumor was less than 3 centimeter size, and no evidence of tumor invasion of blood vessels or lymph nodes. The outcomes was very encouraging. The 4-year tumor-free survival can be up to more than 80%. But another retrospective study from UCLA group, including 467 cases, expand tumor burden as a UCSF criteria. Under the UCSF criteria, more patients can be included into the candidates for liver transplantation, and the outcome was only a little inferior to Milan criteria. In Asia country, living donor is the main source of liver donor. Therefore, there was no controversial issue of fairness. The retrospective and prospective study in Japan showed the tumor burden can be even extended to 5 or 10-5 if the tumor marker alpha-fetoprotein or PICA2 were considered together. The outcome were equal, even better than Milan criteria. Actually, the tumor biology is also very important for HCC recurrence after liver transplantation. So, possible risk factors for HCC recurrence after liver transplantation include tumor markers responsible for TACE, micro or macro invasion, vascular invasion, and the tumor differentiation, and so forth. In Taiwan, the recommended guideline, even recently for HCC treatment, the liver transplantation is still the case with poor liver functions. So in Taiwan, the liver transplantation only reserved for the poor liver function within Milan criteria or UCS criteria. But when the guideline was made, the hepatologist and the oncologist still save space for liver transplantation. That means that if the patient select liver transplantation, they still say yes. But On the contrary, the guideline in Western world, BCLC 2022, already highly recommend liver transplantation as the mainstay of HCC treatment, and the indication are from the very early stage with the mild impairment of liver functions to extended criteria. Even now, under effective immunotherapy, many cases with advanced stage may have the chance of liver transplantation. So, the BCLC guideline for very early stage case, single tumor less than 2 centimeters. If the patients have with preserved liver function, still recommend liver transplantation for the cases with portal hypertension or hyperbilirubinemia. Actually, in our hospital, we had 4,000 fresh cases of HCC case from 2007 to 2017 in 10 years. Among them, 421 cases were very early stage. After multidisciplinary committee decision, the first-line treatment was resection in 1/3, and radiofrequency ablation is about 50%. Let's see the outcome. We use the ALBI score to divide the patient into 2 groups, grade 1 and the grade 2 or 3. We can see the overall survival was beyond our expectation. The 5-year overall survival only about 60%. And if you divide the patient into the group ALBI score 1 or ALBI score 2 and 3, we can see the ALBI score 2 and 3, the patients, the 5-year survival rate only 40%. These results in our hospital echo the BCLC recommendation for very early stage patients. So we discussed with hepatologists and oncologists in our hospital again and again to consider actively recommend liver transplantation to patients with ALBI grade 2 to 3 early stage HCC cancer. Actually, we still can use the transjugular hepatic vein wedge pressure measurement is an objective method to provide portal hypertension, prove the portal hypertension or not. If wedge pressure more than 10 or the platelet count less than 100,000, liver transplant should be actively proposed to patient. For the case within Milan criteria or UCSF criteria, we strongly recommend liver transplantation as soon as possible and can receive TACE or radiofrequency ablation once to twice before donor available. For the intermediate stage case, we will strongly recommend aggressive downstaging study, downstaging tumor status by TACE, RFA, and E319, and immunotherapy even, to be a bridge to liver transplantation. Actually, liver transplantation is still the goal for definite treatment of HCC for cure. For the advanced stage, due to the recent introduction of immunotherapy, some case after aggressive local regional therapy and immunotherapy, the status can become invisible metastasis, and even the tumor status in the liver is within Milan criteria. More now in our liver transplant team, our consensus is that stop immunotherapy, but maintain local regional therapy and target therapy for 6 months, and then observe. After 6 months, we re-evaluate the metastasis. In this case, we will case-by-case discussion. Living donor liver transplantation can be tried, but we should explain the risk of high recurrence rate to the patients and the family. Immunotherapy before liver transplantation can be a downstaging weapon, but the risk of postoperative severe graft rejection should be taken into consideration very seriously. So safe watch out time for the immunotherapy is most important to avoid severe graft rejection. In the cases of liver failure, we cannot wait. How can we prevent and manage the severe rejection? From our analysis, 42 days, 6 weeks should be enough for most immunotherapy medication washout. Although most reports discontinue immunotherapy 3 months before liver transplantation. This is one of our HCC case with immunotherapy without enough washout time, encounter severe graft rejection. We successfully treat the rejection by steroid pulse therapy and 3 times of plasma exchange. So under specific condition, the patient cannot wait until 6 weeks. We recommend, even we use the ATG use, anti-thymoglobulin, and also the plasma exchange, prompt plasma exchange should be done when we suspect the graft rejection. Currently, our patients within Milan criteria and aged younger than 65 years old will be routinely put into deceased donor waiting list. But most cases in our hospital still received living donor liver transplantation. Within UCSF criteria, but beyond Milan criteria, cannot put into the cadaveric wait list, will only receive living donor liver transplantation. But for beyond UCS criteria, only liver transplantation can be provided, but the need case-by-case discussion. And alpha-fetoprotein value is a very important factor of decision. The local regional therapy in Taiwan was used by many hepatologists and oncologists as curative intention before, but recently, as a bridging therapy to liver transplantation is gaining popularity. So we will report our outcome of living donor liver transplantation for treating HCC and evaluate the risk factors associated with tumor recurrence and the impact of pre-transplant local regional therapy. Retrospective study for the case of HCC having living donor liver transplantation from 2004 to 2019, and surgical mortality cases were excluded. The tumor burden was according to the pathology of explanted liver. We analyzed overall outcome, survival, and recurrence-free survival. Median follow-up was 41 months. Male predominant. Child score was evenly distributed in A, B, C. 32% were out of UCS criteria. Most cases were HBV or HCV carrier. The overall 5-year survival rate was 70%. The 5-year recurrence-free survival rate was 80%. The recurrence occurred usually within 3 years after liver transplantation. There was significant difference survival between patients within or beyond Milan criteria. The 5-year recurrence-free survival of cases within Milan criteria was 90%. The survival curve of the UCS criteria was the same with the Milan criteria. When we analyzed the pre-transplant alpha-fetoprotein value, we found the value higher than 500. All cases had HCC recurrence within 3 years and passed away within 5 years after liver transplantation. So the survival was significantly different between patients with or without local regional therapy before liver transplantation. The 5-year tumor-free survival for patients without local regional therapy before transplantation was as high as 100%. The primary liver transplantation, the survival rate is very, very significantly higher than the salvage liver transplantation. How to decrease the unnecessary downstaging to improve tumor-free survival rate after liver transplantation is our preliminary goal. At this study, we analyzed the times of local regional therapy, and over 4 times of local regional therapy had a significant worse outcome. Therefore, we should perform liver transplantation for patients who met the criteria after reasonable downstaging local regional therapy. Local regional therapy as an intention to cure should be avoided. We should try every effort to perform primary liver transplantation and avoid unnecessary treatment of HCC before liver transplantation, except downstaging treatment or donor is not available. The prognosis was associated with patient's severity of liver condition and pre-transplant alpha fetoprotein level. The other significant factor is times of local regional therapy, and this factor is to be the only one we can control, because we know some local regional therapy was used as an intention to cure. It should be avoided. There were also more and more publications with the same result and suggestion as our study. So we still think some contraindication for living donor liver transplantation, as the slide shows. So in conclusion, we think now in BCLC criteria and in Asia, we have the living donor liver transplantation, no fairness problem. So we should encourage patients using the liver transplantation as intention to cure of HCC as possible. So thank you for your attention.